Yes.
Yes, okay. So from today and on the next lecture, we will discuss cerebrovascular diseases. Yes. So moreover, we will say that for today, we will begin to discuss ischemic stroke and transient ischemic attack and classification and risk factors and treatment of the ischemic stroke. On the next lecture will be hemorrhage stroke. So we'll begin. Now, cerebrovascular disorders. No, first we will say about what? Yes, we will repeat, and so I will explain the classification of all cerebrovascular disease. What we will say that all cerebrovascular disorders we can separate to two large groups. This is acute and chronic. So chronic, this is chronic ischemia of the brain, or another term, this is dyscirculation encephalopathy. So acute, what we can say about acute? First, we will say that acute there are first strokes and second transient ischemic attack. Strokes and transient ischemic attack. So how we can subdivide strokes? Yes, so strokes can be ischemic stroke, as today's topic is, and hemorrhage stroke. Ischemic stroke and hemorrhage stroke. So ischemic stroke. Ischemic stroke we can subclass into two groups. First, by the zone of the location, and second one by pathogenesis. By the zone of the location and by pathogenesis. So, by the zone of the location, here what we will say. We know that there are two main systems that are responsible for blood supply to the brain. The system of internal carotid artery and vertebrovascular system. That is why we can subdivide the ischemic stroke by the zone of the location, particularly in what groups? Yes, the stroke in the system of internal carotid artery, particularly anterior cerebral artery and middle cerebral artery. Yes, ischemic stroke in the system of internal carotid artery, particularly anterior and middle. The second one will be stroke in vertebrovascular system. Particularly, this is the stroke in the basal artery, strokes of the cerebellum, and posterior cerebral artery. So, for one more time, yes, in vertebrovascular system will be stroke in basilar artery, then stroke of cerebellum, and posterior cerebral artery. So, tell me please, this information clear for you?
Yes, Doctor, clear.
Yeah, okay, so then the second acute cerebrovascular disorder, as before, this is transient ischemic attack. So here we will say that transient ischemic attack, we can subdivide it to only one group, the zone of the location. This is internal carotid artery and vertebrovascular system. Internal carotid artery and vertebrovascular system, without deviation for anterior, middle, posterior, yes, or so on. Why? Because if we say there is transient ischemic attack in the system of anterior cerebral artery, it means particularly what? That here will be stroke, yes? This is not transient ischemic attack. A little bit later, we will discuss much more close clinical signs of the stroke, of the transient ischemic attack, in the system of internal carotid artery and vertebrovascular system. So then, hemorrhage stroke. Yes, what classification of hemorrhage stroke we can describe? Only by the zone of the location. This is particularly what? This is parenchymal, epidural, subdural, subarachnoid, yes, and intraventricular, parenchymal, epidural, subdural, subarachnoid, and intraventricular stroke. Hemorrhage stroke we will discuss on the next week. Yeah. About classification, all clear or may appear some question? Так,
Yes, yeah.
Хорошо. Okay, so we'll continue. Now, a little bit words about epidemiology. Yes, we know that. So the stroke, so this is the cause of the death of a great amount of people nowadays. Moreover, this is the third leading causes of the death. And annually, 15 million worldwide suffer a stroke, and 5 million are permanently disabled. This is very common cerebrovascular disorder. So then, brain blood supply features, high level of oxygen requirement, then 20% of total body oxygen. So then neurons predominantly aerobic. No, this is the general information. I hope you know it. This is not new, and you studied it on the previous classes. A little bit words about the anatomy, about blood supply to the brain. On this picture, what we can describe that, what arteries. So vertebral basilar system, vertebral arteries, yes, we see. Then they combine together and forming basilar artery. Basilar artery giving the branch for midbrain. Then here we see circle of Willis. On the next slide will be much more detailed. Yes, circle of Willis. The circle of Willis is communication between internal carotid artery and vertebral basilar system. And middle cerebral artery. This is the branch of the internal carotid artery, and we will say that the widest region of blood supply, this is the region of middle cerebral artery. So another picture, yes, much more detail. What we see here, vertebral artery that communicated together in the basal part of the brain and forming basilar artery. Basilar artery giving pontine arteries in the region of midbrain. Yes, then circle of Willis is forming by what arteries? This is the anterior communicating artery. Yes, then this is middle communicating artery and posterior communicating artery. So then internal carotid artery giving ophthalmic artery. You can do the photo of this picture for your class, yes? And the branches of internal carotid artery here we see middle cerebral artery, yes, and anterior cerebral artery. Posterior cerebral artery, this is the branch of the vertebral basilar system, of the basilar artery. And superior and anterior cerebellar artery, they give in the blood supply for cerebellum. Now, the picture like this here of the zones of blood supply of different artery. So here we see the region that's responsible for blood supply of the middle cerebral artery. As we said before, it's the widest region of the blood supply. Occipital zone, posterior cerebral artery, anterior part of the frontal region, this is anterior cerebral artery, and its deep branches. So, the next one. So anterior cerebral artery supplies what region? The middle and superior part of the frontal lobe and the anterior parietal lobe. Then middle cerebral artery. Branches gives rise to arteries that supply the lateral temporal lobe, including its anterior type, and the amygdala, posterior parietal, and much of the lateral occipital lobe. as I have already said before, the widest region of blood supply. Posterior cerebral artery giving what branches? So supply the posterior middle parietal lobe, then splenium of the corpus callosum, then inferior and middle part of the temporal lobe, including the hippocampal formation, and the middle and inferior surface of the occipital lobe. So here's clear.
Yes, clear.
Clear. Хорошо. So, stroke or acute cerebrovascular disorder, defined by a drop honest of the neurological deficit that attribute to the focal vascular course. When we say about ischemic stroke, right, firstly, a little bit, we will repeat several groups of the syndromes. Yes, we know that for all types of the strokes are common. First, focal neurological. And here, like I already said before, yes, defined ischemic stroke defined by abrupt honest of the neurological deficit particular. How we understanding focal neurological deficit? It means that aphasia, then sensory disorder like monoanesthesias or hemianesthesia, then this is damage of the cranial nerves. This is bulbar, pseudobulbar syndrome, central plagiofacial or hypoglossus nerve, for example. Yes, so we're saying that focal neurological deficit will depend on the region of the blood supply in the arteries where happened the stroke. Then the second group of the syndrome, this is general syndrome. General syndrome or cerebral syndrome characterized by what particularly? Headache, disorientation, dizziness, vomiting, yes, general. Then the next one, meningeal. So what is meningeal? This is irritation of the meningeal. And we know that common photophobia, yes, intolerance to the sound, to the light, sorry, then phonophobia, intolerance to the sound, then mucal rigidity, increasing of the muscle tone of the neck, muscles of the neck, yes, then Koenig sign and Brudzinski sign. The group who had, yes, the neurology, I hope they remember those clinical signs, yes. So focal neurological, then cerebral or general, and meningeal syndrome. And can be one more, that groups of the syndrome, this is increasing of the intracranial pressure. Usually the reason, this is brain edema. And in clinical presentation will be losing of consciousness, seizures, no, it's a pity, but even can see the coma. So then the clinical manifestation of the stroke are highly variable because of the complex anatomy of the brain, yes, and its vasculature. Так, here's clear, students.
Yes, clear.
Так, okay. Так, еще раз. So one more time, we repeat that for ischemic stroke, no matter what pathogenetic type, no matter what location, on the first place on the clinical manifestation will be focal neurological deficit that will depend particularly on the zone of location. For anterior cerebral artery, one clinical sign, yes, for the stroke in middle, another, for the stroke in the posterior, another, and so on. Yes, but focal neurological deficit is seen firstly. Now, cerebral ischemia or brain ischemia, what is it? This condition that occurs when there is enough blood flow to the brain to meet metabolic damage. It leads to limited oxygen supply or cerebral hypoxia and leads to the death of the brain tissue, cerebral infarction, or ischemic stroke. So there are two kinds of ischemia. It can be focal ischemia and global ischemia. So focal ischemia, what can we say here? It's confined to a specific region of the brain. And global, this is wide area of the brain tissue. When it compresses the wide area of the brain tissue. So then, global ischemia. What we can say about global ischemia? This is hypoxic encephalopathy, like the variant of the chronic ischemia of the brain. And focal, this is thrombosis, embolism, hemorrhage, yes, or vasoconstriction, for example, when we see obstruction of the blood supply to focal area. The results in clinical presentation, focal neurological deficit. Etiopathogenetic types of the ischemic stroke. Arterial thrombotic type. This means what? Occlusion of the artery due to thrombosis. Cardioembolic type, the reason of this etiopathogenetic type, usually arrhythmic disorder of the heart that leading to the embolism. The results, occlusion of the artery, stroke. Hemorrhagical type. What is hemorrhagical type? Disorder of the blood, yes? Changing of its rheological function. This is hypercoagulation or hypocoagulation, yes? Lacuna. Lacuna, this is small stroke when we see regression usually in 3 days and we're not seeing brain edema. Arterial dissection. Arterial dissection leading to what? Of course, hemorrhage stroke. For arterial dissection, much more common, this is parenchymal hemorrhage with forming of hematoma and unknown causes. But here we can see a little bit, another classification, not etiopathogenetic, yes, but pathogenetic. What difference? Etiopathogenetic, we're understanding in what way? Etiology factors and pathogenesis together. No, like an example, arterial thrombotic type. We know so that the reason usually arteriosclerosis, yes, that leading for thrombosis and occlusion of the artery. Or cardioembolic, we're understanding that this is usually disorder of the heart, much more common. This is arrhythmic disorder of the heart that leading to embolism. But if we will say only about pathogenetic type of the stroke, there are 3 main. This is thrombotic stroke, embolic stroke, and water rash or hypervolemic stroke. This means, yes, thrombotic, this is thrombosis, embolic stroke in pathogenetic variant, this is embolia, hypervolemic or water rash stroke. This is the stroke that happened due to vasoconstriction, when can appear high level of blood pressure or low level of blood pressure, yes, and blood pressure increased. This, for example, hypertonic rise, yes, or decreased. And arterial dissection, we say this is the reason usually for what particularly hemorrhage stroke. Yes. Moreover, in risk factors, we will say that diabetes mellitus, this is the risk factor for hemorrhage stroke much more than for ischemic stroke. And arterial hypertension in much more percent leading for hemorrhage stroke, not for ischemic. But thrombosis, embolia, yes, atherosclerosis, this is the reason for usually ischemic stroke. So, classification of the ischemic events. Like we said before, transient ischemic attack. So, reversible ischemic neurological deficit and cerebral infarction. 3 main. Transient ischemic attack, reversible ischemic neurological deficit, and the last one, this is infarction of the brain. So what we can say about transient ischemic attack? So transient ischemic attack, this is the episode of the temporary reduced in perfusion to a focal region of the brain, causing a short-lived disturbance of function. Usually this is 24 hours. So the patient experienced in temporary focal neurological deficits such as speech disorder, aphasia, slurred speech, then monoocular blindness, can appear hemianopia, yes, absent of the half of the visual field, weaknesses, paralysis of limbs, but we're saying that this episode lasted not more than 24 hours. After 24 hours, we need to see the regression of the clinical sign. If more than 24, we're saying about the stroke. Yes? What stroke can be lacuna or a large stroke, we don't know. So symptom will depend particularly in what area transient ischemic attack appear. We know it can be in the internal carotid artery or vertebrovascular system. Yes? But on the first place, for the clinical manifestation of the transient ischemic attack, in all cases will be focal neurological deficit. That is why we're saying in what way that patients in whom we see suddenly appearing of the focal neurological deficit, they need to be hospitalized in short period of the time, very, very quickly, as quickly as possible, because we don't know what it will be. Is it transient ischemic attack or it's stroke? So, reversible ischemic neurological deficit, what is it? This is like small or lacuna stroke. Focal brain, this is the same term, yes? Focal brain ischemia, in which we see the deficit improves over maximum of 72 hours. Usually we're saying 3 days. After that, need to see the regression. Reversible ischemic neurological deficit, or this is small stroke. So deficit may not completely resolve in all cases. Some slight changes in the neurological state still can be present, but of course it will not be such rude variant of the plagues, for example, and paralyzed like we see in large strokes. Yes, now in reversible ischemic neurological deficit, for example, muscle power can be 4 borals. Yes, this is very, very slight, and it's not influencing in the conduction of life of the patients. Cerebral infection. So, permanent neurological disorder, the patient presents with fixed deficit. Can present in 3 forms: stable, improving, and progressing. So, in stable, what we will say, neurological deficit is permanent and will not improve or deteriorate. Improving, I hope you understand what it means, return of the previous lost neurological function over several days to weeks. And progressing, the neurological status continues to deteriorate following the initial onset of the focal deficit. Maybe some period of destabilization followed by further progression. Usually in progressive form, we see appearing on the brain edema. So, this picture of what? Yes, atherosclerotic clot in the artery, blood clot, this is thrombosis. And showing for us coronal section of the brain showing middle cerebral artery. Very common zone of the stroke. Clinical features, as we have already said before, yes, clinical symptoms depends on the area of the cerebral circulation that affect and on the extent to which is affected. Here we see what? So tell me please, who know what is describing here? The disorder of what nerve? Whom remember? This is what? Central plagia of the facial nerve. Suffering lower mimic muscle. Asymmetrically of the angle of the mouth on the contralateral side of the damage. The zone, this is middle cerebral artery. Then the second illustration, the same, showing what probe. This is barrier test, upper barrier test. On one side, we see normal muscle power fibrils in the right arm, in the left, the arm going down, yes, much more lower than on the line that it need to be, and we will say that here muscle power 3 bores, yes, paralysis of the arm, and the same asymmetrically of face central plagia of the fascial nerve. So risk and risk factors for the stroke. There are two groups, modifiable and unmodifiable. So what mean modifiable risk factors? That we can correct, yes? We can influence it on them. Unmodifiable, we cannot influence. Unmodifiable, which is age, yes, we cannot stop the aging, gender, race, previous cerebrovascular disorders, yes, and heredity. Modifiable, this is hypertension, then smoking, alcohol abuse, disorders of the heart, diabetes mellitus, hypercoagulopathy, different variant, and pregnancy, cancer, and so on. This is factors that we can influence on. Yes, we can correct the level of blood pressure. We can recommend the patient to stop smoke or taking alcohol. Yes, if the patient have diabetes mellitus, we will correct the level of glucose. So, brainstem stroke, common pattern. This is pure motor and pure sensory. So, sure, very important. Those questions having on your test. Yes, and not to have confusion, particularly on its difference. Sometimes while checking your test, seeing that I'm having some confusion in this question. Pure motor and pure sensory. Pure motor mean weaknesses of face and limbs on one side of the body without abnormalities of the high brain function, sensation, or vision. The region, middle cerebral artery, anterior cerebral artery. Pure sensory, decreased sensation of the face and limbs on one side of the body without abnormalities of high brain function and motor function or vision. So, pure motor, face, limbs, yes, weaknesses on one side, high brain function, sensation, vision, safety. Pure sensory, decreased sensation of face, limbs on one side, so high brain function, motor function, and vision, safety. Understood here? I hope will not do, yes, the mistake in future. Internal carotid artery occlusion. So, may range from a transient ischemic attack to infarction of the major portion of the ipsilateral hemispheres. What neurological symptoms common? Contralateral monoparalysis with or without affection of vision. Impairment of speech, language, and transient monoocular blindness. So, like, yes, middle cerebral artery, yes. Then, illustration. In this illustration, what we can describe? This is the patient with transient ischemic attack. So here we see angiography. This depicts a large plagia involving in the internal carotid artery, characterized by a proximal calcified component and distal fibrinolytic portion. Here, see, and here the same. No, two, not so good thing. No? Here's much more better. Let's see. So, middle cerebral artery. What common features for the stroke in middle cerebral artery? Paralysis. Where? On the contralateral side, face, arm, and leg. Impairment of sensation on the contralateral side, of course, yes, on the face, arm, and leg. Then, hemianopia, homonymous hemi or quadrantopia. Yes, as two variants can be said. Paralysis of the gaze to the contralateral side, aphasia, It can be seen when the stroke happened in dominant hemisphere. Two types of aphasias can be wernicke's and Broca, yes, motor and sensory aphasia. Then, contralateral hemiplegia and paralysis, we have already said about it, and slide speech. This is the picture of the middle cerebral artery. Its anatomy showing its branches where they are situated and giving the blood supply to the brain, and we see that responsible for giving the blood supply from the Broca's area, yes, Wernicke's area, then precentral gyrus primary motor cortex, postcentral gyrus primary sensory cortex. Yeah. MRI of the stroke. So area of the element corresponds to the left middle cerebral artery, superior division territory. Here is the ischemic stroke. When you will analyze the picture of the hemorrhage stroke, there are too hard to say that if it's white color, this is hemorrhage, gray color, this is ischemic. No, all will depend in what regime we will do or we did MRI. This is ischemic stroke in one picture and another, but in the first it's in white color, in the second it's in gray color. Yeah? The question is in what? How to differentiate? When it's parenchymal hemorrhage, hemorrhage stroke, it's like round. But here we not see in such way. Yes, this is the different regions around it. It's not like round. Yes, we can see the sulcus here. And the same, the stroke in the middle cerebral artery. It's a large stroke. Arterial cerebral artery stroke. So paralysis on the contralateral foot and leg. Sensory loss over toes, foot, and leg. Will be a payment of the gait and stand, abulia, flat affected, and cognitive impairment. We know that orbitofrontal region responsible for cognitive function, for behavior, motivation, adaptation, and emotional sphere. Can be disorder of urination. The picture of the stroke in the anterior cerebral artery. Here we see MRI and yes, the zone of the stroke. We will say that, and in the previous pictures that we analyzed, and here, so usually the stroke no more than 10 days. We see if it's young stroke, like after 1 day, you will not see such picture, even in MRI. Posterior cerebral artery stroke. What clinical sign will be? Disturbances of vision, contralateral homonymous hemianopia, then bilateral vision, this is cortical blindness, then impairment of memory if the temple is affected, then proximal occlusion, here will be contralateral hemisensory loss, spontaneous appearing pain, like in thalamic syndrome, and contralateral severe proximal area. Now the picture of the stroke in the posterior cerebral artery. Here we see in the zone of the stroke. This is CT scan on one side and on another. The same, we cannot say that this is like round, isn't it? That's usually typical for the hemorrhage stroke. On the next lecture, when we will discuss hemorrhage stroke, you will see difference about with hemorrhage and ischemic stroke in the MRI. Vertebral basilar system. What neurological signs and symptoms can be? Vertigo, nausea, vomiting, losing of balance during walking, dysphagia, then ipsilateral cerebral ataxia, diplopia, losing of the visual field, gaze paralysis, decreased pain and temperature discriminations. Penumbra. So what is penumbra? When happened the stroke, we see the zone of the infarction, yes, local region of infarction. Around the zone of infarction, forming the zone of penumbra. So this is the area surrounding an ischemic events such as in ischemic, thrombotic, and embolic stroke. We will say that in the zone of the penumbra, the neurons, they are trying to save their functional activity. Yes, due to this, they decreasing its functions. To be vigilant, the neurons have already can influence and to save the zone of the penumbra, to increase the speed of the blood supply in the period of the therapeutic window. What is therapeutic window of the stroke? Maximum 4, maximum 6 hours. Now, some years ago we said 6. Now we say 4 hours. Yes, if in this period we will prescribe for patient correct treatment, will influencing on the pathogenetic factor like thrombosis, yes, embolia or vasoconstriction, and will increase the speed of the blood supply. It means that the cells that are in zone of the penumbra, they can save their functional activity and will be alive. That will be the illustration. Ischemic stroke in the system of the middle cerebral artery. This is dead tissue, central region of the ischemia. Here we can do nothing. And around the zone of the penumbra, the neurons that they are alive, their functional activity decreased because they try, yes, to save its function. Yes? And here they say this is infarction around the ischemic zone of the penumbra. Zone of the inflammation, of course, will be around, yes. So examination. Now, what examination need to be? Of course, blood test, yes. So then auscultation of the carotid blood, then examination of the heart, as for valvular heart diseases, especially mitral stenosis, then pulse, arrhythmic, particularly arterial fibrillation, yes? And this is like general investigation for all patients, not even with the stroke, but with a great amount of different disorders. And then, moreover, identify conduction which may predispose towards the cerebrovascular diseases. Then, flow blood count, level of the glucose, yes, in the patient with diabetes mellitus, of course, we need to control it. Serum lipids, then blood cultures, yes, protein screens, thrombophilia screens, yes, and thrombophilia protein C, protein S, yes, and antithrombin. Instrumental investigation. This is echocardiogram, ultrasounds of carotid arteries, not even carotids, and of course the cerebrovascular system need to investigate. This is very important. Why? To prove or exclude, is it thrombosis, is it embolia, or then CT and MRI. So first time investigating the patient in the hospital, this is CT scan. Why CT? What not MRI? The task for us to separate and to differentiate, is it hemorrhage stroke or ischemic stroke? Yes? And first, CT scan is investigation not taking a long period of the time. Moreover, due to specialty of investigation, the patient's under control. We see in them the patients. Moreover, CT scan much more better seeing blood than MRI. First, doing CT scan, seeing blood, like parenchymal hemorrhage. Saying about the hemorrhage stroke, not seeing any changes, treating the patient like the patient with ischemic stroke. MRI we usually doing after 2 days. No, 1-2 days, all will depend on the patient. If the patient in stabilization conduction as feeling normal, in normal consciousness, we will do MRI after 24 hours, we'll repeat. If we see some problem with the vital function, after 48 hours. And of course, cerebral angiogram. The illustration, ultrasound of carotid artery. Same occlusion here of carotid artery. Computer tomography, we have already sorted before the zones of the stroke. This is what region? Middle cerebral artery. Yes, in right middle cerebral artery. MRI. In these pictures in the development of the day. First day, like seeing nothing, a little bit zone. After 3 is much more wider, and after 28 days, we see the forming zone of the stroke with gliosis. Yes, absolutely another picture. Angiogram. So angiogram that showed occlusion of the internal carotid artery. I hope you're seeing it. The stopping of the speed of the blood supply here. So, with what disorders we need to differentiate the stroke? Cervical trauma, meningitis encephalitis. Now, of course, the meningitis of encephalitis, we're saying about what? Subarachnoid hemorrhage, because in subarachnoid hemorrhage, on the first place, will appear meningeal syndrome. Then, hypertension encephalopathy. Usually, hypertension encephalopathy in the background of the hypertonia crisis leading to transient ischemic attack. And we know that on the first place appearing focal neurological deficit, and we don't know is it transient ischemic attack or it's stroke. So then intracranial mass, tumors and hematomas, migraine. Yes, in migraine we see appearing and focal neurological deficit and meningeal syndrome. Multiple sclerosis. What we know about multiple sclerosis? That in multiple sclerosis, suddenly, without any predominant factors, can appear in focal neurological deficit. What particularly? For example, the classical variant of the development of the clinical sign that common for multiple sclerosis, this is optic neuritis. Suddenly appearing blindness in one eye or hemianopia. Can it be in stroke without any problem? Yes. So, and different metabolic changes, hypoglycemia, yes, or drug abuse, for example. So, here is the picture and diagram of the risk for transient ischemic attack. Like we said before, you can do the picture of it, yes. What? Speech duration. This is presenting, combining all of the different risks and changes that we said before. Yes, risk for this and after calculation. We will say that this is what is lower intermediate So this problem with my internet, okay, we'll continue. Are you hearing me? So for one more time, tell me please, are you hearing me or not? Yes, okay. Слава Богу, thank God. Так, давайте тут a little bit we'll finish. I hope it will not stop. Так, so tell me please, is it opened? Yes? Okay, just one moment. So, and the next, yes? So, in complications, what we will say. So, cerebral edema, yes? Then hemorrhage transformation can occur as a result of the thrombosis. No, we said about it before, yes? Then pneumonia, then anxiety and depressions, then no, emotional ability. We said about it. All right, we will see next slide. Treatment, much more important. Treatment, acute ischemic stroke. So this medical support, then thrombolytic therapy, then this is surgery treatment and the vascular techniques, and antithrombotic treatment. Antithrombotic treatment we prescribe for the patient in whom contraindicate thrombolysis. So medical support, pneumatic compressions talking to the prevent of the development. Then about controlling of the level of glucose, we say less than 6 and 1. Then water restriction and mannitol may be used to reduce of the serum osmolarys. Mannitol forward to prevent the brain edema. Yes, for those students who have already had the classes, they know that usually we give in mannitol not from the beginning of the stroke, not from the 24 hours. Usually this is the ending of the second day. Why? Because when we see a period of the focal neurological deficit, we don't know what it will be. Ischemic stroke or transient ischemic attack. If it's transient ischemic attack, or that this is a small stroke or lacuna stroke, in this case, we will never see brain edema. Due to this, it's no need to give the mannitol. And if we see development of the clinical sign and appearing of the clinical sign of the brain edema, in these cases, we're giving mannitol or glycerol. Mannitol much more better. Moreover, we will say, not need to forget about it. It's not from the beginning, ending on the second day, after 48 hours. Yes? Then, intravenous thrombolysis therapy. This therapy will be pathogenetic treatment for the patient who having thrombotic stroke. Here we see in what way? Seeing thrombosis, prescribe thrombolytic therapy. Not seeing the zone of the thrombosis, cannot prescribe. This is the mistake. Thrombolysis, especially recombinant tissue plasminogen activated, to be given only within the first 3 hours after onset of those patients who have not development CT abnormalities, especially in the patient with basilar artery occlusion. This will be contraindication. Said ischemic stroke within 3 hours. What this can be? This is hemorrhage. In some patients we see it, in some not. To say that this is our mistake, we cannot. This is the result of therapy that can be seen. And the vascular techniques. Thrombolytic via intrathecal flow and in enzymatic system bleeding complications. And the vascular mechanical thrombectomy. So used in patients who are inhaled for or have contraindications for thrombolytic therapy. I hope you understood. In such groups of the patient in whom we can give thrombolytic drug, we can do mechanical thrombectomy. Now, this is the same, have a great risk. So, and antithrombotic treatment, the same. We can give it in patients in whom contraindicate thrombolytic therapy. What particular? This is aspirin. And so anticoagulant, lower molecular weight, like heparin, one or another group of the drug. The same will be what? Pathogenetic therapy. So this is the same slide. Yes, the same as about aspirin and ticlopidine we can give. Ticlopidine has been proven to be effective, to be effective in the secondary prevalence of transient ischemic attacks and the stroke. A great variety of drugs. In some patients, one much more better, in other groups of the patient, another. And anticoagulant, like we said before, this is warfarin. Surgery treatment. This is different techniques nowadays we're having. Yes, this is carotid enterectomy, and this is stent placement. So the surgery on the first technique, what we will say, surgical removal of the anterior malformations and so on for the patients with uncreated lesion clot that occlude much more 17% of the blood flow, and moreover in ultrasound on the artery, yes, in Dopplerography, when we see decreasing speed of the blood supply and less than 60%, yes, of the blood flow in the carotid artery, we say that this not need the surgery treatment. If it is much more 17%, this and the last one, stent placement. Yes, then here we see different techniques of the operation. This is what we are opening the carotid artery, then placard is removed. After that, repaired in the stroke, maybe. No? And тоже here we say like this is stent. Close stent. After that, it's open the artery and increase the speed of the blood supply. Those doing the surgery. Yes. So, and act facts. No, usually this is describing these act facts like in American Stroke Association, like face dropping, weaknesses, slight speech, no lose the time, need to call. Yes, FAST. So, and this is the material that you can use when you will prepare for it. I am online or not? So students, I am online periodically, да? Periodically appearing, periodically disappearing. So, так, now hearing for me or not? Да, очень хорошо, it's very good. So, for today, about the lecture of the ischemic stroke, what question do you have? All clear?
Yes, madam.
No, so it's good. No, much more detailed variant, you will discuss it on the classes with your teachers, okay? Так, so, значит, for today, тогда we finishing on the next week at 15:30, yes? By the shoulder. We will discuss we will discuss hemorrhage stroke, okay? So, тогда wish you good evening, and on the next week waiting for you at the same time in the Zoom, okay?
До свидания.
So you are welcome. Bye.
До свидания.